Hello, I'm Dr. Maegen Dupper. I am a family medicine physician here in the medical education department at CUSM, and I want to share with you an overview of clinical precepting and some context for you who are training our students in the clinical environment. So our agenda for this brief session is to review where this training fits within our four-year program, as well as some expectations for our preceptors, students, and hopefully to be able to give you some idea of the benefits of engaging in training our students. I want to point out where our four-year program encompasses clinical education and start with a review of our pre-clerkship education. The first 18 months of their education involves foundational courses where they're learning the foundational concepts of medical knowledge, anatomy, physiology, pharmacology. They're also getting a significant amount of clinical education in our clinical skills department and simulation. They're training with standardized patients to be able to take a history, complete a physical exam, build their differentials, and at that point, at 18 months, they're ready to join the clinical phase of their education and their training in the clinical setting. The next phase of their education is their clerkship phase with 12 months of core clerkship training, and as well as a 6-month professional development semester. Lastly, our students progress into their fourth year, where we're supporting their transition to residency. In this slide, you can see how the students have a choice when they enter their clerkship phase of education. They have a choice to enter directly into their core clerkships, and in other schools and sort of traditional model of education, that would have been later in their third year. The students are well prepared at 18 months to enter directly into that core clerkship training. Alternatively, they can enter into their professional development semester and participate in electives and other types of clinical training. You can also see that means there's some overlap of cohorts. As students progress in these examples here from class of 2026 and class of 2027, there are students that may be working with you at different points in their career. You could have different levels of learner on your clinical care team. They are all well prepared and ready to help train each other, as well as support the care of your patients. A couple of other details I want to share about the professional development semester. The students in that semester are supported in a course that's directly supporting their USMLE Step 1 and Step 2 preparation for those licensing exams. They also are supported in opportunities for electives, both in the sort of traditional sub-I and audition style rotations, as well as other electives. They also are participating in electives and more informal training to support our community, to engage with work that their training and learner position allows them to be able to do. Lastly, I want to highlight that many of our students use this 6 months to participate in research, and the definition of research for those students is expansive. It can be clinical research, quality improvement work within a need from your clinic, or any of those scholarly activities that we know will help their training and their application for residency. This semester is truly developing them professionally and supporting their growth towards graduation and residency training. Next, I want to discuss the core clerkships. So those 12 months of core clerkship training encompass what I hope are a very familiar set of traditional core clerkship departments the students are rotating through. They're rotating through 8 core clerkships in internal medicine, general surgery, family medicine, OB, peds, psych, emergency medicine, and neurology. Those core foundational experiences are really important for their training and their progress to obtaining the MD. The aspect that is unique to CUSM, that is effective and we know contributing to a high quality education, is our dual pass model. So each of these clerkships are split into 2 rotations on a dual pass semester system. The exception is emergency medicine and neurology, where students rotate through those in a single 4-week pass. So you can see in this example schedule, a student may choose to start on their general surgery rotation and spend the first 4 weeks rotating through that formative first pass of general surgery. And then they'll continue on in the internal medicine first pass and then complete their single neurology rotation. As that student progresses through, you can see they return in the second semester, about 6 months later, to return to their general surgery and complete the second 4 weeks with a summative experience, with all of that first pass experience, understanding, and development even in their cultural approach, their understanding of our system, and how to be able to act. I also want to point out within this dual pass system that students are receiving assessments, both formative and summative feedback throughout the 12-month cycle. In their first semester, students will take NBME exams for those dual pass clerkships and have the chance to take a second pass when they repeat the summative second and final iteration of the rotation. Neurology and emergency medicine, again, the students complete NBME assessments for those. You are also receiving your feedback and your assessment of their performance. I'd like to share where the assessments for students' performance in their core clerkships land and how your appraisal of their performance when they're rotating with you and taking care of your patients, where that's represented in their transcript and their overall grades and dean's letter. So you can see here that 30% of the student's core clerkship grade is comprised by the component of a faculty's evaluation of their clinical performance. We recognize that those clinical skills, those communication and abilities to express their clinical reasoning and document it is crucial to the training of any MD. Of course, that's also comprised and balanced by the importance of their medical knowledge and their assessments of their ability to move forward in the training and completion of those required clinical experiences. So diving a little bit deeper into the details of how a preceptor such as yourself would be evaluating a student, you will see within our learning system a set of assessments that will be assigned for a formative and summative evaluation of students. We hope it is something that you can be familiar with, that's not onerous, and are always happy to answer questions related to it. A few common questions that I get I'd like to address and hopefully make things easier for you. Our scale is a 6-point scale that we determined over care in our years of developing this curriculum to be able to identify high-performing students at the level of 6 who are exceptional compared to their peers, compared to what we would expect the level of a medical student. Contrast that to a student who we would appraise at a level of a 4 on this scale. Means they're consistently performing these skills with your supervision and support, but they can do it. And in a simple term, that correlates to passing. A student who's doing a good job, who has these skills, we can confidently evaluate on a 4 in this scale. A couple other questions that come up often is how we interpret the expectations. And I want to point out that our evaluation is based off of AAMC national standards of entrustable professional activities. Of course, we've adjusted those to meet our community of practice needs and to make sure that we're training students to be our future colleagues. Having said that, it's important to note a few of the specifics. So if you'll see here, we want to make sure that students know how to enter and discuss orders and prescriptions. It's item 4. We recognize that our students are not licensed physicians. They can't enter orders and sign them. However, we can always have their orders be a verbal discussion. What would you order for this patient? What do you think is the next step for this patient? And those kinds of conversations ensure that they have that skill set and are ready to move on in their training. Another example of questions that I'll get is general procedures, as well as making sure that we know how to do handover and recognizing emergent issues. All those pieces are really crucial for our students to be able to participate in, even if they're not the sole decision makers of this piece of care. Lastly, I want to point out an example for obtaining consent. So we want our students to be able to recognize when is informed consent required? What are the components of it? How would you start that conversation with a patient? And what are some of the common concerns or questions that a patient might have? We do not expect students to complete informed consent on their own, but they need to have this important skill. So to summarize, evaluations are important, and we really value your careful consideration and appraisal of our students' performance. And I really appreciate the time and attention you give to these. I want to move on and highlight just a couple other things that can be relevant to you as a faculty member who's training our students. One of them is the other component of the student's overall grade, which is their required clinical experiences. We sometimes will call that their patient log or use the abbreviation of RCEs. What this is a list of items that our students need to complete. They need to be able to engage meaningfully in this type of experience throughout the 12 months of their core clerkships. These are in our syllabus and online, so I'm going to share them as an overview. You can review. Our goal here is for students to participate meaningfully, actively, and with independence, of course, and supervision for the majority of them. So I want to point out that these our goal for these is bread and butter cases. We want these to be things that they encounter in the usual course of participating on rounds, in your clinic, in your post-op follow-up patients. There should not be difficulty in finding or accessing the student's exposure to these experiences. Of course, if there is, please let us know. Our students are also well aware of this list and can help facilitate their engagement themselves. And as you can see, bread and butter cases, infections come up pretty often in our line of work. At the end of the list, there's a few that you'll note are designated with a P, meaning we don't necessarily expect our students to independently complete these experiences, but we want them to be able to participate. You'll notice that also aligns with higher level procedural care, such as vaginal delivery. So as a reminder to where we are in the course of our 4-year program, I've just reviewed the clerkship phase of education, what our students are doing in that professional development semester, as well as some of the overall expectations and role of you as a clinical preceptor in the clerkship phase of education. I want to share a little bit more about the transition to residency and what happens in that 4th year for students. Our students are rotating and maybe working with you as a sub-intern in that 4-week audition-style rotation where they're really completing and participating activities at the level of a 4th year or nearing the level of an intern. We want those experiences to be valuable for students within one of our core clerkship departments. Sometimes students will also continue their sub-internship experiences into the rest of their electives. Do about 26 weeks of electives throughout their 4th year, getting experiences that serve their career needs as well as their interests, because it might be the last time they ever get a chance to do that. As a clinical preceptor, you might notice a difference in their performance, a difference in their ability and independence, but we use the same assessment to be able to get to our goals of those EPA-based outcomes on their MD performance. I also want to point out we do a couple of other required courses for students, including a preparation course prior to their transition into residency, just after match, to be able to support their review. And of course, we partner very closely with our Student Affairs Department to provide residency application support, as the bulk of so much of their time and energy in 4th year is geared towards that application process in the fall. So I'd like to summarize a few key points on expectations for our students in this space. We want active participation from our students. Our expectation is that they're a part of the team, that they're participating in these outcomes and curriculum actively for their own training and their career in the future. We want them to be a key member of discussions for clinical practice so that, again, they become our colleagues and help take care of our community. We also expect, of course, that engagement to align with attendance and communication. When events happen, flat tires and whatnot, our students are well aware of the importance of their role and are expected to communicate effectively. And to make sure that you're aware of what their expectations are, what their needs are, and in return to be able to meet them and be a reliable member of the team. So a few key points for expectations for ourselves as we are training students in the clinical environment. As faculty, we are supervisors. As attending physicians, we're attending to the students' participation and making sure that we're providing the highest quality care for our patients. In that same space, we're supporting our students in the learning environment and making sure that they have what they need to gain those skills and to progress forward. That means supporting them and recognizing our specific policies with duty hours, mistreatment, and ensuring that we collaborate if there's any specific needs, such as an accommodation for a student. And I would recommend reading through these and some of the other materials that are provided. Also, as faculty who are training our students, we need to be able to give them feedback in a timely, formative, and summative manner. So our evaluations and how we give that feedback to students, both in the moment and written, is crucial for their training and to be able to ensure that they're meeting the milestones in their progress. Lastly, I want to highlight an additional thought, which is if there's any issues, concerns, questions about a student or your role as a faculty within our curriculum, please don't hesitate to communicate that to our clerkship directors, to myself, to anyone in our medical education team. Now that I've reviewed the curriculum and where a faculty preceptor's role fits within this MD program, I want to emphasize how appreciated you are and how much the work of training students and caring for patients is recognized. And we want to support that wherever and however possible here at CUSM. Faculty physicians have meaning and purpose in what we do. I know for myself especially, it's important to recognize that I'm training my future colleagues. We also want to support you at the university level in your academic career, your growth, and your interest in continuing that academic training for yourself. At the university level, our departments of Information Commons and our librarians, as well as our faculty development office and faculty affairs office, are here to support you. If you have questions, any thoughts, any needs, please don't hesitate to reach out. We'd be happy to hear from you. Thank you again. Thank you for your time in watching this video and in your interest and effort in training our students. Thank you.